The lung is one of our amazing organs. Fortunately, we have two. And the human being takes about 23,040 breaths every 24 hours. Isn't this amazing? The trachea appears first in the fourth week of gestation. The bronchial tree is fully developed by week 16 of intrauterine life. At birth, the number of branches from an axial airway varies between 15 and 16. We have about 300 million alveoli, and they develop after birth, increasing in number until the age of 8 years. Alveoli are microscopic structures not visible radiographically. The size of the alveoli increases until growth of the chest wall finishes with adulthood. In reference to the blood vessels, we can divide them into preacinar and intraacinar vessels. The preacinar vessels follow the development of the airways. They have many more branches along its length than the airway it accompanies. There are 3 times as many supernumerary as conventional arteries. The veins outnumber the arteries. If we look at the embryologic study of the pulmonary arterial tree, the pulmonary trunk depends on the septation of the truncus arteriosus. The right and left primary divisions of the pulmonary trunk, so-called right pulmonary artery and left pulmonary artery, depend on the development of the 6th aortic arch. And the intrapulmonary arteries are the result of the proliferation of angioblastic mesenchyma. The intraacinar vessels follow the development of the alveoli. Interaction between epithelium and mesenchyma is essential to normal cell development. The branching and remodeling of the bronchial tree requires a normal investment of mesenchyma. The acinus is the respiratory unit of the lung and is supplied by a terminal bronchiole. In the adult, it is about 5 to 10 millimeters in diameter, and at birth, 1 to 2 millimeters. Note here the classification of the airways based on the average diameter and the common name of each structure. Note that the very small airways, which are the bronchioles, terminal bronchioles, respiratory bronchioles, and the respiratory unit of Miller, are invisible radiographically speaking, even on high-resolution computed tomography. Note that the terminal bronchiole gives off respiratory bronchioles, which are characterized by having alveoli in their walls. That means that they participate in air exchange. The respiratory bronchioles, after they branch, they produce alveolar sacs. And from the alveolar sacs, we have the final destination of the air, which is the alveoli. And the respiratory unit of Miller is the primary unit consisting of the very distal airway, that is the alveolar space. There are about 300 million alveoli in the adult lung with a surface area of 7 to 80 square meters. When we look at young subjects compared to older people, we note that in older people there is a decrease in the number of alveoli and a relative increase in the air ducts. That contributes to the picture of the so-called senile lung, which is a lung that lacks very small distal vessels and has an increase in the blackness of the lung due to a relative increase in the air spaces. The alveolar ventilation normally is about 350 milliliters. That means that of the half a liter inspired air, 350 go into the alveoli and 150 remain in the dead space. That is, that they do not participate in air exchange. The alveolar ventilation per minute is about 350 times 12, 4.2 liters per minute. In a subject weighing about 74 kilos, the lung volumes are 4.3 milliliters, the alveolar surface about 143 square meters, the capillary surface is 126 square meters, and the capillary volume is just 213 milliliters. When we look at a total lung capacity of about 4.3 liters, we note that always at the end of a full expiration, there is always a residual volume. Note that the tidal volume is just a small volume as we compare it to the inspiratory capacity, which includes the tidal volume and the inspiratory reserve volume. We also note that on forced expiration, we still have air remaining in the airway. This is a diagram of John West, an outstanding pulmonary physiologist, who described the air-blood inhomogeneity in the lung. That is, that in areas of the lung that are close to the apex, the pulmonary alveolar pressure exceeds the vascular pressure. And this, he believes, explains why in the upright view we see a paucity of the pulmonary vasculature and relative increases in the amount of air. And that explains the air-blood inhomogeneity of the upper zones. In the lower zones, the vascular pressures exceed the alveolar pressure. And that's why there is a prominence of the pulmonary markings, not only because of the relative increase in the volume of the lower lobes compared to the upper zone, and because of gravity, but because of this phenomena that relates to gravity. That is, that air finds its way easier to the upper zones, but blood finds its easier path towards the dependent part of the lungs. In the middle third of the lung, or what he calls zone 2, the pulmonary arterial pressure exceeds the alveolar pressure, which exceeds the venous pressure. And we see a relative normal relationship between vessels and air. In the upright view of the chest, we appreciate the air-blood flow inhomogeneity. Note the prominent markings of the lower zone, again, as a result of a relative larger volume that demands more blood, but also because of gravity, there is a cascade phenomena, so that the blood that comes into the mid portion of the medial aspect of the lungs finds an easier path towards the lung bases. Note conversely that in the upper zones around the clavicle, we see a relative decrease in the number of vessels. That means that there is a relative increase in the amount of air. Air tends to rise, blood tends to go down. And this air-blood flow inhomogeneity, ventilation, perfusion inhomogeneity accounts for the differences in the appearance of the vessels in upright view of the chest. This is very important because, as we shall see in subsequent lectures, there are situations where the vascularity of the lung is decrease or increase in a uniform or in a focal fashion, and this may be the only abnormality present. So a departure of the normal relative increase in markings in the lower zones is a sign of pulmonary pathology as far as ventilation and perfusion. This is a frontal view of a right lung. The lung has been inflated and fixed with formalin. Note that the medial convexity projects beyond the medial aspect of the left lung, and this is the portion of the lung that forms the anterior line of pleural contact, and is the portion of the lung that covers the mediastinal structures. Sometimes it contacts with the opposite lung to form an inconstant air soft tissue interface that is called the anterior junction line. Note that in the surface of the lung we see a mosaic pattern, particularly in the lower half of the lung. This is because the interlobular septa appear impregnated with hemosiderin, and hemosiderin-laden macrophages explain the purple color of the connective tissue of the interlobular septa. Sometimes anthracotic pigment also outlines the connective tissue of the interlobular septa. This is the right lung seen from a lateral perspective. Note the obliquely directed major fissure, which forms about 45-degree angle with the horizontal plane. Also note separating the middle lobe from the upper lobe, the minor fissure. Also observe distinctly the interlobular septa, which is a very small anatomical structure that contains acini. The latter are best visualized on high-resolution computed tomography. This is the anterior aspect of a left lung. Note that here we have the interlobular septa impregnated with anthracotic material, and that produces a blue-black color. Note that the transverse diameter of the left lung is smaller than the right because it accommodates part of the heart at the level of the so-called cardiac incisura, which is seen in the medial aspect of the left lung. Here we see the lateral view of the left lung. Note the long major fissure, which forms about 60-degree angle with the horizontal plane. And this is important because on lateral views of the chest, when we see an oblique fissure that forms about 45 degrees, that should correspond to the right lung. And when we see a fissure that forms about 60 degrees with the horizontal plane, this should represent the left major fissure. So actually the left lung has an anterior and a posterior lobe. We call the anterior lobe the left upper lobe, and we call the posterior lobe the left lower lobe. In this lateral picture of the left lung, there is an extra fissure, which is indicated by the red arrow. This is a fissure that sometimes can be seen separating the superior from the inferior segment of the lingula. In other words, the left upper lobe has the lingular segment, which is the one that surrounds the heart. It has the form of a tongue and therefore the name lingula. And the lingula has a superior and inferior segment. And those two segments occasionally can be separated by the presence of a minor fissure. It's the counterpart of the right minor fissure. Sometimes this fissure is complete or it can be incomplete as indicated in this specimen. Note the medial aspect of the right lung. Note that the medial surface is shallow, and this will contrast with the medial surface of the left lung, which has the cardiac incisura to accommodate the heart. Here we see the medial aspect of the left lung. Note that in front of the left main bronchus, we see a concavity, and that is the space destined to house the left side of the heart. So most people have the heart predominantly in the left hemithorax, and this is made possible by a concavity of the left lung. Therefore, the left lung transversely and volumetrically is smaller than the right. In this specimen, we can see the presence of an extra fissure that separates the superior from the inferior lingular segment. And this is an extra fissure that is the counterpart of the right minor fissure. This is the dorsal view of the right lung. Note that its anterior portion projects more medial than the dorsal portion of the right lung. And this anterior portion of the right lung, when it contacts the similar segment of the left upper lobe, forms the so-called anterior junction line. And the anterior junction line may or may not be seen on frontal view of the chest. If there is abundance of fibroadipose tissue, we will not see the contact of the two lungs in front of the heart and mediastinal structures. In this photograph of the left lung, we see also the medial aspect of the left upper lobe projecting beyond the medial surface of the left lung. And this is the portion of the left upper lobe that contacts the one on the right to form the anterior junction line. Any mass that arises from these two segments, that is the anterior portion of the two lungs, the most medial portion of both, can simulate an anterior mediastinal tumor. This is a bird's eye view of the right lung. Note how the right upper lobe projects medially beyond the medial surface of the right lung. Here we see the medial portion of the left upper lobe in this bird's eye view of the left lung projecting beyond the medial surface of the left lung. Also note a very well demarcated cardiac incisura. This patient presented with myasthenia gravis and was thought to have a thymic tumor. The frontal view of the chest shows a density close to the left hilum. In this lateral tomogram, we can faintly see the outline of a mass which projects in front of the left hilus. The injection of the left internal thoracic, so-called internal mammary artery, revealed very small vessels supplying this mass. At surgery, this proved to be a bronchogenic carcinoma arising from the medial aspect of the left upper lobe. The patient did not have myasthenia gravis. The patient had carcinomatous myasthenia. Because the tumor arose from a medial portion of the lung, it simulated a mediastinal tumor, such as a thymic mass. If we were to inject a color plastic in each of the bronchopulmonary segments and we would photograph the surface of the lung, we would see that the outline of the space between the different bronchopulmonary segments generally are not straight lines. Only we see straight planes at the level of the fissures. So for example, in this view of the right, the lung, the apical segment is separated from the anterior and posterior segments of the right upper lobe by an irregular plane. A medial view of the right lung shows that the outline of the space between bronchopulmonary segments is not a straight plane. And you can see that between the apical and posterior segments of the right upper lobe, and also one can see it between the superior segment and the basilar segments of the right lower lobe. Note the sharp demarcation that occurs at the level of the fissures. In this patient, there was an extra fissure between the lingula and the anterior segment of the left upper lobe. Note that between the superior and inferior segment of the lingula, we do not see a straight line. The straight line that we see between the lingula and the left lower lobe is formed by the plane of the left major fissure. When color plastics are injected into each segmental bronchus, we can see this feature of irregularities in the outline of the various bronchopulmonary segments. Note between the apical, anterior, and posterior segments of the right upper lobe, a zigzag pattern. Also note that the straight areas of demarcation correspond to the right minor fissure and to the right major fissure. This same irregular outline is noted between the various basilar segments and between the superior segment of the right lower lobe and the basilar segments. The medial aspect of the right lung also shows clear demarcation at the level of the right minor fissure, but an irregular outline of the space between the various bronchopulmonary segments of the left lower lobe and also between the segments of the right upper lobe. A lateral photograph of the left lung where color plastics were injected into the various lobes and bronchopulmonary segments revealed that the left upper lobe is really an anterior lobe, and there is a sharp demarcation between these two lobes. However, at the level of the bronchopulmonary segments, we note an irregularity in the areas of demarcation between the various bronchopulmonary segments. Finally, we see the medial aspect of the left lung, and note the cardiac incisura, which is formed by the medial surface of the superior and inferior segment of the lingula. Note that the left upper lobe has only two bronchopulmonary segments, which are the anterior and the apical posterior. In other words, that the right upper lobe has three bronchopulmonary segments, while the left upper lobe has only an anterior and an apical posterior segment, as well as a superior and inferior segments that correspond to the lingular portion of the left upper lobe. The latter is the counterpart of the right middle lobe, and because of the presence of the heart, the orientation is not medial-lateral as seen in the right middle lobe, but superior-inferior as seen in this photograph. Parenchymal opacities have been described as alveolar and interstitial. The terminology of alveolar should be reserved to indicate the filling of alveoli and tiny terminal air spaces by a water density substance, while the term interstitial should mean the increase in the size of the walls of the alveoli, the septa, and the peribronchial and perivascular sheaths. Unfortunately, most parenchymal lesions of the lung affect both the intra and extra-alveolar structures. That is why we prefer not to use the terminology of alveolar and interstitial. The only pure alveolar process is alveolar proteinosis, a disease where only the intra-alveolar space is affected. And the only interstitial process that we see pathologically is the early phase of pulmonary edema, so-called interstitial pulmonary edema. Later, the edema, when it affects the intra-alveolar structures, cannot be distinguished if it is interstitial or if it is alveolar. So we prefer to use other terminologies. When we see a pulmonary density or a pulmonary opacity, we're talking about radiographic density, meaning that we see a grayish or white area in the lung. It can either represent a consolidation or an infiltrate, or can represent atelectasis. Infiltrates and consolidations are the same descriptive word for a process where the air in the alveoli has been replaced by something else. And that something else can be a fluid like edema, or the aspiration of fluid, can be blood, that is hemorrhage, can be an inflammatory process, usually pneumonias, that can be infectious or non-infectious inflammations, can be a tumor, particularly the bronchoalveolar cell carcinoma, or can be alveolar proteinosis. So the pathologists, like the radiologists, when they feel a firm area of the lung, and this corresponds to an opacity, we should describe it as they so do pathologically as an infiltrate or consolidation. If we see an area of the lung where air has not been replaced but has been absorbed, and usually the oxygen is absorbed first and finally the nitrogen, an airless portion of the lung should be referred to as atelectasis. And there are two types of atelectasis. One in which the central airway is obstructed and there is no collateral ventilation to maintain the physiologic and anatomic integrity of the lung distal to the obstruction, and this is called then central atelectasis, as seen with a foreign body, with a mucus plug, with a tumor, etc. And then we have peripheral forms of atelectasis, where the lack of surfactant produces a collapse of the distal airway, and radiographically and pathologically the proximal airway is open, but not the terminal air spaces that appear collapsed. The latter is also seen when the lung parenchyma is compressed by a process due to elevation of the diaphragm, or a process arising from the chest wall, or even the heart pressing on the lung. So those are conditions that can produce a peripheral forms of atelectasis. In order to get the peripheral atelectasis, we don't have to have an abnormality of the surfactant that keeps the alveoli distended at all times. In this obese subject, the lower zones appeared white. Does that mean that this patient has pleural effusions, a parenchymal disease, or could this be an error of technique? A subsequent radiograph taken a few seconds later, with the patient taking a better breath and exposing it slightly better, shows that the lower zones do not have pathology. In other words, underexposed films, and particularly in obese individuals or those who have ascites with poor inspiratory effort, may show pathology, what looks like pathology in the lower zones, when actually we're seeing simply the results of underexposure or of sometimes compressed lung by an elevated diaphragm. Here we see a color diagram of the three segments of the right upper lobe. One is the apical, two the anterior, and three the posterior. Note that the anterior and posterior segments are superimposed, but that the lateral portion of the anterior segment does not touch the chest wall, while the lateral portion of the posterior segment reaches the right chest wall. Also note that the anterior segmental bronchus is in proximity and part of the right hilus. So a density of the anterior segment will be close to the hilus. A density in the posterior segment generally does not reach the medial aspect of the right upper lobe. Here we see the three segments of the right upper lobe, the anterior segment that touches the anterior chest wall, the posterior segment which touches the posterior chest wall, and the apical segment which is above these two other bronchopulmonary segments. So the lateral view easily distinguishes the location of a parenchymal process when the frontal view may not be specific as to its location in the right anterior segment or the right posterior segment of the right upper lobe. This is a sketch showing the location of pathology in the apical segment of the right upper lobe. Note that it projects above the clavicle, both in the frontal and in the lateral views of the chest. This is a sketch of the anatomy of the anterior segment of the right upper lobe. Note that it contacts the hilus, but laterally does not reach the chest wall. In the lateral view, we can see that it reaches the chest wall anteriorly, but does not reach the chest wall posteriorly. In this sketch of the posterior segment of the right upper lobe, note that in the frontal projection, it touches the right chest wall, medially does not reach the hilus. And in the lateral view, it contacts the posterior wall dorsally, but does not contact the anterior chest wall ventrally. Note an area of consolidation in the right upper lobe. Its sharp inferior outline is produced by the bowing of the right minor fissure. This means that there is a mass effect that occupies the entire right upper lobe. What could it be? Well, this consolidation was the result of a pneumonia, but any type of airspace filling process can lead to this type of abnormality. When seen as in this radiograph, we must suspect an infection or we must suspect a tumor. Conceivably also blood could fill entirely the right upper lobe and produce this large area of consolidation. Note also that the right hemidiaphragm is elevated. In this other patient, we also see consolidation of the right upper lobe, but here we note a little bit of air in the apical segment of the right upper lobe. This turned out to be another pneumonia, and that will be the first differential diagnosis. When we see a mass effect with uniform whiteness, we should call it consolidation. If the density is discrete, we can call it infiltrate. The same conditions that produce consolidations produce infiltrate. In this patient, we note the consolidation of the right upper lobe, but here, the lateral aspect of the right minor fissure is slightly higher than its medial aspect. This means that there is some degree of volume loss of the peripheral portion of the right upper lobe. Note that there is air in the bronchi close to the hilus. How do we describe this process? We should describe it as an area of consolidation. The fact that air is seen in the proximal airway indicates that there is no central obstructing process. In other words, this will go against this process of being a central neoplasm. In this patient, note diffuse opacification of the right upper lobe with a very sharp inferiorly concave minor fissure. And the opacity is indicative of volume loss because of the superior displacement of the minor fissure. The normal position of the minor fissure should be equidistant between the right clavicle and the right dome of the diaphragm. So the volume loss is a definite abnormality. And the question is, what is it due to? Well, it is atelectasis secondary to obstruction of the central airway of the right upper lobe bronchus. Possibilities: foreign body, a tumor, a stricture, a compression. This turned out to be endobronchial tuberculosis. This is the Luft-Sichel sign, and it consists of a lucency that may be observed medially when there is atelectasis, as indicated by the arrowheads. There is bronchial relocation whenever there is loss of a segment or a lobe, and aeration surrounding the area of atelectasis, in this case, is what produces the Luft-Sichel sign. In this case, the atelectasis was due to a cancer. This is a patient with axillary pneumonia. Note that diffuse infiltrate in topography of the posterior segment of the right upper lobe. It is demarcated inferiorly by the minor fissure and laterally it touches the chest wall, sparing the right hilus and also the right apex. So the anatomic location should be posterior segment of the right upper lobe. This is what is called an axillary pneumonia because in the lateral projection of the chest, the density projects at the level of the axilla, as will be seen in the next picture. Note the opacification of the posterior segment of the right upper lobe, demarcated inferiorly by the right major fissure, as noted by the arrows. Note that the density does not reach the anterior chest wall, so it is located in the posterior segment of the right upper lobe. And this projects at the level of the axilla. That's why the name axillary pneumonia, which means a pathological process involving the posterior segment of the right upper lobe. In this diagram, we note the two bronchopulmonary segments of the right middle lobe, which are one medial and the other one is lateral. The medial one contacts the right heart border, so whenever we see indistinctness of the right heart border, we must suspect the pathology involving the medial segment of the right middle lobe. In the lateral photograph of the chest, the medial segment of the middle lobe touches the anterior chest wall, while the lateral segment of the right middle lobe only touches the right major fissure, but not the anterior chest wall. This is a sketch showing the projection of the medial segment of the right middle lobe. Note that it is limited superiorly by the minor fissure and it contacts the right heart border. Laterally, it does not reach the chest wall. This is a sketch of the lateral segment of the right middle lobe. Note in the frontal projection that it does not reach the right heart border medially. Laterally, it touches the chest wall. Superiorly, it is demarcated by the right minor fissure. In the lateral projection, we note that it does not reach the anterior chest wall, and it is sharply demarcated superiorly by the right minor fissure and inferiorly by the ventral portion of the right major fissure. This patient had a pneumonia of the medial segment of the right middle lobe. Note the indistinctness of the right heart border and note also the superior sharp demarcation formed by the right minor fissure. Note that the triangular density does not reach the chest wall laterally. In the lateral view of the chest, we note the medial segment of the right middle lobe with an area of consolidation. Note that it touches the chest wall anteriorly, and it is demarcated superiorly by the right minor fissure and inferiorly by the right major fissure. This patient had a microcytic cell carcinoma of the bronchus to the right middle lobe. Note the complete atelectasis with volume loss, with indistinctness of the right heart border, and a sharp superior margin due to the contact of this density with the right minor fissure. The volume loss was due to endobronchial process, in this case a cancer. The lateral view of the same patient shows the complete atelectasis of the right middle lobe with sharp superior and inferior boundaries due to the contact of the middle lobe with the minor fissure superiorly and the major fissure inferiorly, and the volume loss is radiographically apparent. This is an apical lordotic view which shows the sharp triangular shadow of an atelectatic right middle lobe. This patient had asthma, and the mechanism of the atelectasis was the presence of a mucus plug. Apical lordotic views can better delineate the atelectasis of the right middle lobe. This is a sketch showing the outline of the superior segment of the right lower lobe. Note that in the frontal projection it appears quite high, and in the lateral projection it touches the chest wall posteriorly. It is delineated sharply anteriorly by the posterior aspect of the right major fissure. This patient had a rounded density that proved to be a lung abscess. The question is, where is it located? Because of a sharp right minor fissure, it should not be neither in the upper lobe nor in the middle lobe. The fact that we see the minor fissure with fluid in this case suggests that this lesion is located in the superior segment of the right lower lobe. The lateral view of the chest confirms the location of the lung abscess in the superior segment of the right lower lobe. This is a sketch showing the location of the anterior basilar segment of the right lower lobe. Note that in the frontal projection it does not reach the chest wall, and it is demarcated inferiorly by the diaphragm. Here we see an infiltrate in topography of the anterior segment of the right lower lobe, exactly the same anatomical location as illustrated in the previous diagram. Here we see a sketch of the anatomic location of the lateral basilar segment of the right lower lobe. In the frontal projection, it reaches the chest wall and touches the diaphragm inferiorly. In the lateral projection, it does not reach the posterior chest wall and certainly does not contact the anterior chest wall. In this lateral view of the chest, we note a lesion in topography of the lateral segment of the right lower lobe, which proved to be a hamartoma. This is the sketch of the medial basilar segment of the right lower lobe. Note that in the frontal projection, it may be confused with the medial segment of the right middle lobe. However, the right heart border should be sharp because this basilar segment is behind the heart. In the lateral view of the chest, it does not reach the chest wall posteriorly and touches the diaphragm inferiorly. This is an example of a pneumonia involving the medial basilar segment of the right lower lobe. Note that we still see distinctly the right heart border. Therefore, it is not in the medial segment of the right lower lobe. The pneumonia in the medial segment of the right lower lobe is shown in this radiograph. It does not touch the chest wall posteriorly, and in this case, it did not extend all the way down to the diaphragm. This is a sketch of the posterior basilar segment of the right lower lobe. In the frontal projection, note that it reaches the diaphragm inferiorly, and it should project always behind the heart. In the lateral projection, we note that it contacts the chest wall dorsally and the diaphragm inferiorly. In this lateral projection, we note an area of consolidation occupying the posterior basilar segment of the right lower lobe. Note that it contacts the chest wall dorsally. In this frontal view of the chest, we note an infiltrate in topography of the right lower lobe. Where is it? In the lateral projection, it was located in the posterior basilar segment of the right lower lobe. This is an extensive infiltrate due to pneumonia, and quite often pathological processes, particularly infection, occupy more than one segment and more than one lobe, in which case they are referred to as multifocal pneumonias. The location was in the right lower lobe predominantly. So this is a multifocal pneumonia due to tuberculosis, and it occupied several segments of the right lower lobe. Here is a sketch of the first bronchopulmonary segment of the left upper lobe, which is called the apical posterior. Note that it reaches the chest wall in the frontal projection, and it occupies also the apex, but it is away from the left hilus. This patient had a pneumonia in the apical posterior segment of the left upper lobe, exactly in the same anatomical location as shown in the previous diagram. This sketch shows on your left the frontal view of the chest, where we see the anterior segment of the left upper lobe, and in the lateral projection it touches the chest wall anteriorly, and therefore remember that the left upper lobe has only two bronchopulmonary segments, the apical posterior and the anterior. This patient had a mucocele, so-called mucoid impaction, exactly in the anterior segment of the left upper lobe. Note that the finger-like density that is noted in topography of the anterior segment of the left upper lobe. The reason that there is no atelectasis is because collateral ventilation through the pores of Kohn and the channels of Lambert maintain aeration distal to the obstructed bronchus. The lingula has two bronchopulmonary segments, a superior and inferior, and this is a sketch of the superior segment of the lingula. Note that it is seen in the mid portion of the left lung, and it is in contact with the heart. In the lateral projection, we can see that it is demarcated dorsally by the left major fissure, and ventrally it touches the anterior chest wall. This patient had a mass, which we can call it also neoplastic consolidation, in topography of the superior segment of the lingula. Note that it produces indistinctness of the left heart border. Therefore, it is a lesion in an anterior location. The same patient in the lateral projection reveals the cancer in the superior segment of the lingula. This is a sketch of the inferior segment of the lingula. And note that it is located just below the superior segment of the lingula. It touches the heart border in the frontal projection. And in the lateral view, we can see that it touches the anterior chest wall anteriorly and the diaphragm inferiorly. This patient had multifocal pneumonia. An infiltrate is seen at the level of the left hilus, and the other large infiltrate occupies primarily the inferior segment of the lingula. Note the indistinctness of the left heart border. In this lateral view of the chest, we note that the heart has an added density. In other words, the density is at the same level of the heart. And because it produces an indistinctness of the heart border in the frontal projection, the lateral view confirms that we're dealing with an infiltrate in topography of the lingula, and primarily the inferior segment was involved. Here we note the diffuse opacification of the left upper hemithorax. Note the indistinctness of the left heart border. Note the sharpness of the aortic knob, which is indicative that the density is not in the plane of the aortic knob, which is a dorsal structure. Because of the indistinctness of the left upper lobe and volume loss of the left upper lobe, one has to suspect the atelectasis of the lingula. In the lateral projection, we note the complete atelectasis of the left upper lobe. The left major fissure is displaced ventrally, and there is a hyperexpansion of the left lower lobe, which, as you remember, it is a dorsal lobe. The cause of this atelectasis was a cancer affecting the left upper lobe bronchus, involving the two segments of the left upper lobe as well as the two segments of the lingula. This is the Luft-Ziffel sign in a patient with left upper lobe atelectasis. There is a volume loss of the left upper lobe, and this is best seen in the lateral projection, where the sharp left major fissure appears displaced ventrally. Surrounding the area of atelectasis is the curvilineal radiolucency, which has been designated as the Luft-Ziffel sign. This is a sketch of the anatomic location of the superior segment of the left lower lobe. Note how high it is in the frontal projection. In the lateral view, we can see that it is demarcated anteriorly by the dorsal aspect of the left major fissure, and dorsally it touches the chest wall. This child had fever and chills, and we see a rounded consolidation in topography of the superior segment of the left lower lobe. Why couldn't it be the lingula? Because the left heart border is sharp. The lateral view of the chest confirms the anatomic location of this rounded consolidation that is in the superior segment of the left lower lobe. It proved to be a rounded pneumonia. This is a diagram of the anatomic location of the anterior medial segment of the left lower lobe. Because of the presence of the heart, the left lower lobe is smaller than the right lower lobe, and therefore some bronchopulmonary segments have to be missing or be hypoplastic. In this case, the anterior and medial basilar segments have coalesced, and we can see in the lateral projection that it projects inferiorly against the diaphragm, but does not reach the chest wall neither ventrally nor laterally. This patient had bibasilar changes. On the left side, note that the density touching the diaphragm, and the heart border is relatively sharp. There is another density in the lateral aspect of the right base. Both prove to be pulmonary infarcts, which cause a hemorrhagic consolidation of the lung. This is a diagram showing in the frontal projection the anatomic location of the lateral basilar segment of the left lower lobe. Note that it touches the chest wall laterally and the diaphragm inferiorly. And note that it projects in the middle portion of the left base demarcated anteriorly by the left major fissure. This patient had multifocal pneumonias that, because of the anatomic location in the basilar portions of the lung, one should suspect aspiration pneumonia. Note that there is indistinctness of the right heart border, indicative that the right middle lobe is involved. And note in this frontal projection that the pneumonia reaches the left chest wall and silhouettes the left dome of the diaphragm. And this was because it affected the basilar segments of the left lower lobe. The posterior basilar segment of the left lower lobe is illustrated in the frontal and lateral sketches. Note in the lateral view that it touches inferiorly the diaphragm and the chest wall dorsally. This patient had a cavity in topography of the posterior basilar segment of the left lower lobe. The cause of this cavity was Wegener's granulomatosis. The fact that the cavity touches the chest wall dorsally locates the cavity in the posterior segment of the left lower lobe. In this patient, there was atelectasis of the left lower lobe. Note the hyperlucency due to hyperexpansion of the left upper lobe. And also note that we do not see the left hilus, which is covered by the displaced heart to the left of the midline. In the lateral view of the chest, we see evidence of a hyperexpanded left upper lobe, producing that hyperlucency in the ventral aspect of the left lung. And note the density that is plastered against the posterior chest wall, which represents the atelectatic left lower lobe, in this case due to cancer. A density in the projection of the lung may not be in the lung itself, but in the pleura. And here you can see the sketch that represents fluid in the right minor fissure. We can see that it has sharp margins superiorly and inferiorly. Here we can see the classic elliptic density of interlobar effusion. The density is not in the lung. The oval shape of this density with the sharp superior and inferior margins and a little tail that is directed towards the hilus is pathognomonic of interlobar pleural effusion.